We've been battling this for years.
I couldn't pay attention at all.
Adults come up and cuss him out right in his face, saying he's rude and obnoxious.
I was falling over to the one side all the time.
I couldn't stop moving my head.
My head was resting on my right shoulder. Went to the orthopedic surgeon, chiropractor.
I've been on almost every single medication you can think of.
Tegretol, Haldol,
Artane.
Different medication, basically month to month, until there was none.
I started treating children with headaches for TMJ, which is the prime cause of headaches. That's temporomandibular joint dysfunction. I was asked to give a talk on headaches in children. I was going through about 400 cases, and I noticed all these people had movement disorders of one kind or another. By the end of the treatment, the movement disorders had disappeared. They had what's called an internal derangement or dislocated jaw joint. An internal derangement was common to most of these maladies, which was the underlying everything.
This is the initial appointment of a patient who comes to me with gait problems, meaning walking disabilities, and all the typical symptoms of a Tourette's patient. She also has the symptoms of a TMJ patient.
I attended a seminar, and Dr. Brendan Stack was one of the presenters. And he showed some videotape of some of the movement disorder patients that he had treated. And what I saw was how the application of dentistry can actually help those who have movement disorders.
Here she gets up from this adjustment, and you can see the difference in her physical well-being. And here she is that same day, several hours later.
I think she will have to pick up from here if she is to take this year's championship.
There was a skater, she was Britain's champion, and she had a specific disorder where it was very difficult for her to walk.
When the appliance is inserted into her mouth, she takes a deep breath.
Was it someone giving your life back? All of a sudden, the body started to work. I only can describe it like a battery, and the battery has been used up. The minute that that appliance went into my mouth, the battery was recharged.
That's when I knew I had to know what was going on. I wanted to know the depth of how his work was changing the lives of these people.
My symptoms were twitching, I had barking noises, I would twitch my neck back and forth, cause myself whiplash. It's amazing. I mean, I've always wanted looked at people and just wishing that I could just stay still.
And over the summer, he changed high schools and went to another one. So the girls in the new high school wouldn't know he had Tourette's. Now he's got some girlfriends.
Yeah.
I had extreme pain. For the longest time, I didn't know who to turn to or where to look. As soon as he put it in my mouth, it was just an immediate release of the tension in that area.
Lamar was treated at the University of Maryland. He's had Tourette's since he was 7. He came to see us the day after he went to the University of Maryland, and they were going to prescribe some Valium, some drugs, so forth and so on. We made him an orthotic, and he discontinued all his tics. We got an invitation to the University of Maryland, the top neurologist there, and we did a little presentation there. But I also brought Lamar, who was their patient. Lamar did not have his orthotic in, So he had his tics going, as you know, and you can see them, the neurologist, you know, looking at the side of their eyes, is saying, "Why is he here?" And I said, "Seeing is believing." And then I told Lamar to put his orthotic in, and once he put it in, he stopped. And if you want to see a bunch of faces hit the floor, the trigeminal nerve, it is the largest cranial nerve in the body. It is majorly a sensory nerve. It has one motor portion to it, but it actually applies to the eyes, to the nose, and to the mouth. We believe it is in the peripheral nerve that the signal starts, and it is an aberrant or bad signal that goes into the brain stem, because that's where the trigeminal nerve actually goes to. Once it goes into the brain stem divides it and goes, one signal goes to the brain, and the other signal goes to the limbs. Removing that aberrant signal causes the head to actually correct itself, or the limb to stop. This is why in those Tourette's patients, you see them stop. In the dystonia patients, you see them stop. In the gait disorder patients, you see them corrected.
The thinking now related to the oral orthotic, in a way, redefines aspects of what the brainstem does or what's going on in the brainstem, and specifically the fact that at the heart of it appears to be this notion of inflammation.
Down and relax, and you'll...
Let me make a suggestion. Nerve trauma is a nerve that has been entrapped between bones and irritated. It's inflamed. It's misbehaving. It's sending the wrong signals.
Relax it and let it go back. The idea being to apply pressure.
Before I discovered this entrapped nerve in my nose, I was pretty much expecting to have to retire and never work again. And so the question is, which nerves are involved, and how do they work, and how do they interact with the neuromuscular system to produce these conditions? We're going to take a look inside my brain, and hopefully be able to put it back together again before the end of the day, and see if there's anything that can be detected by some rather sophisticated techniques.
When it says relax on the bottom of the screen, I want you to move your orthotic out of its correct position.
A lot of times something new will come along, and that'll tell us that there's something we don't know and gives us something to look at. Now we have evidence that a dental appliance can help people that have motor problems some distance away from their jaw. That's a very new piece of information. So we have to take that seriously and examine it. I think the next step is really trying to understand how it works and why it works. When you put a dental appliance in, how does it change the brain, and how does that change in the brain affect your behavior and how well you can control your muscle movements, well you can control
the results are absolutely striking. It kind of shakes it really shakes the foundation of what we've thought. In medical school, we're taught that these movement disorders originate in parts of the basal ganglia, deep gray nuclei in the brain. This brings a different twist to that thinking. I think it does tell us that we have an awful lot to learn.
My training as an ice skater gave me the determination to pursue this journey that I've been on and not to give up. It's not about you go to a doctor, he puts this in your mouth and that solves all your problems. Don't go in thinking that I have got a cure. I think that it's still very much in its infancy.
Thousands of people out there have these disorders. Once we understand the underlying mechanism, there might be even better method of treatment that nobody's tried yet because they didn't understand what was wrong.
Why should putting something in my mouth make such a difference to me? Why should I be able to then access all the different areas of my brain and able to run a very successful company? And I would not have been able to do it. I would have been sitting in a chair as a vegetable.
We're excited that with this appliance that he's not going to have all those stares all the time and people looking at him.
I could totally pay attention. I could read. I've never read so well before in my entire life.
I feel very good now, rather excellent.
It's like I don't have Tourette's anymore.
the door's been opened. We now need them to really open and look and see what's inside. Here's a gift that we've been given. How can we now make it flourish? What we've got is just the tip of the iceberg.
You look at the origin of neurology and what we've already learned, it's unbelievable, but at the same time there's so much we do not know. And now with other imaging techniques, we can learn so much more, and I think these are tools that create a ripe opportunity to be able to understand exactly what's happening. It's a very exciting prospect.
As of the current time, 2011, I've been in practice 47 years as an orthodontist. Approximately 18 months after I became an orthodontist, I started to treat TMJ patients. Basically, I was bored with orthodontics and found out that I had a talent for treating craniofacial pain. Approximately 25 or 30 years ago, I was asked to do a lecture on craniofacial pain and TMJ problems in children. This was at a time when everybody knew that TMJ problems were an old person's disease. They didn't occur in children. So in preparation for this talk, I spent weeks going through 400 cases of patients that we had treated for TMJ disorders to try and pick out the children, if there were any. And in reviewing all these cases, I noticed that a large majority of these patients had movement disorders, either not enough movement or too much movement. I wasn't sophisticated enough to know what all the labels meant, like dystonia, dyskinesia, blepharospasm, Tourette's, Parkinson's. All I knew is that they all had in common some type of movement disorder. Many of these children were similarly affected, and I noticed that when I was through treating these patients, their charts showed that the movement disorder had disappeared at the same time their headaches and craniofacial pain was no longer existing. I started to think that there was a connection between the two. I happened to be located immediately adjacent to an MRI center where the radiologists work at NIH, or National Institutes of Health, and come over at night and interpret all the MRIs that have been taken during the day by various technicians. In fact, it is the chief radiologist at NIH, Dr. Petronis, who reads my images. He is the United States government's top radiologist and is known throughout the world. I found that all these movement disorder patients had in common an internally deranged temporomandibular joint. Either the disc was out of place in relationship to the condyle and stayed out of place or went back into place, or the disc was in its normal relationship to the condyle, but the condyle and the disc complex were in malrelationship to the posterior slope of the eminence. Either way, by correcting this internal derangement that we diagnosed in these patients, not only did their pain and headaches go away, but their movement disorders dissipated also. This young man presents at age 15 with multiple facial tics, including grimacing, as well as the obvious ones to the viewer, as well as vocal tics. The motor tics started at the age of 10, and the vocal tics started at the age of 11 and a half. His MRI was negative But keep in mind the fact that there were motion artifacts on the MRI and it wasn't as 100% conclusive as it would be on a non-Tourette's patient. But the main tip-off was that he had 100% deep bite, meaning his upper incisors completely overlapped his lower incisors when his teeth were in occlusion. 20 anatomical areas, usually meaning muscles, were sensitive to palpation with 4 ounces of pressure. Also, as you observe him going through these movement disorders, notice the hypertrophy of his right sternocleidomastoid muscle. Most of these patients will have cervical involvement as well as cranial and facial involvement, and the muscles will be hypertrophied in many cases, and cervical spine x-rays will begin to show initial degenerative change due to all the function that has been imposed upon the cervical spine. His tics began at 10 years old with his motor tics, vocal tics began, and we're going to have great success with him because we've put in our tongue blades and just brought everything to a screeching halt. And you did that last night, right? And how many tongue blades did you determine stopped it?
It seems that 5 is good for him.
5 is good for him. Okay, we'll have the appliance back tomorrow, I believe, and we'll put it in, and we'll start at that height or close to it, and just go from there. And we'll make you an upper appliance to take care of his cranial compensations. Right? We agreed on that yesterday, I believe. Okay. And I'm expecting very good results from this right away. This shouldn't be too difficult.
Okay.
And you remember our agreement, right? Our deal?
Oh, yeah.
Okay. Good. Okay, that's all for today. These are the patient's moles showing his habitual bite in centric occlusion. Notice the deep bite of the incisors, where the maxillary teeth completely obscure the lower incisors. Notice the maxillary right teeth in the buccal segment are lingually inclined when compared to the maxillary left teeth, whose buccal segment is more upright. These are indications of cranial distortions in the maxilla and will need to be taken into account in this patient's orthodontic treatment later on. Okay, let's just get some idea. Open. Wait. Is that about the height? That height feel familiar to you?
Yeah.
This wouldn't come off of that for a minute. I thought we were just going to have to send you home like that. Okay, oh boy. Lift up a little. When you're old like me, you don't like to bend over so much. Okay. Is that hurting you in any way? Digging into your gums in any way?
Nope, none.
Hurting your teeth in any way?
Nope, none.
Okay. Okay, we're going to start treatment today. This young boy. It happens to be 20 minutes after 3. We're going to fit him with this lower mouthpiece for this movement disorder. You can see all these Tourette symptoms he's got going. And we're going to realign his mandible to his cranial base using this mouthpiece. This is a substructure for it, which the laboratory has fabricated for us overnight. We're mixing soft acrylic now, and we're going to put a new surface on it. We've determined that the vertical dimension we're going to start with is 5 tongue blades high, because we have given him tongue blades to experiment with last night, and he's been varying the tongue blades up and down in his motel room, and he's determined that 5 is a good starting point for him.